implementing person-centered care, we have not much research results actually when we're looking for it. There are a lot of articles telling us about educational projects and implementation projects, but results and the effects of implementing this type of person-centered care, there's quite a lack of such articles and research when we search for it. So, but this short presentation is focused on challenges when we implement it. You know, we are starting up a new project within the activities of Gothenburg Person-Centered Care Project, and it is to introduce PCC into the psychiatric clinics in Gothenburg, University Hospital in Gothenburg. And this needs a lot of activities. I have wrote them down on this slide. We have to educate the personnel, the staff, mapping existing routines, adjust them to person-centered imperative. We have to start the intervention, collect data, find validated instruments that we can use. For example, the first one, DLDR, is one instrument that we didn't have from the beginning. It was a tool that we developed actually and tailored to empower the patient to play an active role in constructing a care plan. And the work to bring this instrument was proceeding of 1.5 years. And now we have an instrument that is validated and that we have tested the reliability. And there is an article that is under review for the moment. And after that, we have to analyze it all, produce text, publish, have new audits, adjust the project, and hopefully see a diffusion. So such a project is huge. It's a large investment, and it needs a lot of skilled persons or people that work with this and researchers and so on. So my question is, did we forget something when we were starting up such a project? We know that we have a tendency to be quite naive when we start something new in the healthcare sector. Quite often do we have some type of linear idea or mechanistic perspective of management control and of change actually. But when we look backwards from different projects that has been, we can see that the healthcare sector, its organization are surely not mechanistic. It's very, very organic and quite difficult to control when we start something new. Rogers did look at 24 of very successful change projects, big change projects. And he said that if you look at this Gauche curve, he said that half of the staff is innovators, they are adopters, early adopters, and we also find the early majority. And half of the staff are the opposite, they are the late majority, and we also find 16% of laggards, those who don't want to see this change. But that was successful change projects. When we look at the change projects that wasn't successful, all of those, we can of course see a quite strong skewness in this curve. And we can find maybe 90% late majority or even laggards that is resisting the change project. So that's the real challenge often. We can have good ideas, we can have conferences on PCC, and we can talk about this in decades. But when we shall implement it, it's when the project becomes sharp, and we meet the staff in the organization. So in order to be prepared for what will come in the next stage, we did within this project, as well as the other projects on the general medical care clinic and also orthopedics that we heard before, started up with a study on resistance to change. And we used OREX instrument to break down resistance to change to 4 different categories. We looked for routine seeking, a reluctance to give up old habits. We looked for emotional reaction, where change is a stressor, a short-term focus when it's hard to adjust to a new situation, and also cognitive rigidity that corresponds to some type of dogmatism and a closed mindset. And we measured that in the different wards in the clinic. And what we found in the psychiatric clinic was a little bit disappointing, because we found more cognitive rigidity in the psychiatric care, the blue line here, than in the other clinics, the medical clinic and the orthopedic clinic. However, we continued the study and also looked at the characteristics of culture within those wards. And when we took the results from the characteristics of cultures and did regressions at resistance to change, and we used the cultural results as an independent variable and resistance to change as a dependent variable, we found that the dominance of a culture that is flexible, where we have a strong cohesion between the staff and there is a strong trust within the clinic or the ward, actually decreased resistance to change. And especially it did decrease the blue line, the cognitive rigidity, especially in the psychiatric care, you could see. So that was quite interesting. So what we hoped for, it was that we would find a lot of this flexibility in the psychiatric clinic and in the wards, and that we would find a lot of this flexibility and cohesion culture. So we looked at our figures and were a little disappointed once again, because the psychiatric clinic had a little less of this flexible cohesion behavior than the other clinics, the medical clinics and orthopedic clinics. And it's red in this figure. You find psychiatry down to the left. However, we found this character, and we also presumed that this character was quite important during this implementation project. And we digged a little deeper in this. So here you have the different wards and primary psychiatric care, and the culture of flexibility is blue now in this picture. You can find that it is quite different distributed between the different wards. So we could see that some of the wards did have quite low degree of this culture, and some of the wards had more of it. So now, after this measurement, we were a little more prepared, and we also had the data and studies from the medical clinic and the orthopedic clinic, and we knew that we could see effects from this. So we could pinpoint actually wards where we could maybe give an extra helping hand during the implementation of the project. Some conclusions from this. I think you agree about the first point here. The implementation process is easier in some healthcare settings more than others. And it also, of course, have some type of reason. The next one could be a little more difficult because we are not so used to it. Before an investment, assess and predict the possible outcomes. We wouldn't have any private company in the world that should invest in a new market without doing some type of feasibility study. But we tend to invest millions and a lot of effort to change things, and often we get disappointed because we don't see that change that we expected. And the third point says, give the conservative, because we find them, the backward-looking and part-dependent parts of the organization incitments to change. Very often we lean on the middle manager or we lean on the senior manager, and say that they should fix this. They should control the staff in such a way that we can see the change fulfilled. But maybe we also should look in another way. There is a concept that says non-monetary property rights, and maybe we should value that a little more. You know, resources, non-monetary resources, that is actually more or less more important than salaries. Salaries are of course important, but you have other types of resources. For example, being proud for your competence, and actually being proud for what you are accomplish in the organization. And one other thing that is also quite important, it is what they call organizational fashions. If a new model is spreading out from organization to organization to organization by diffusion and gets very popular, it's very difficult to resist the change in the long run.